How is renal reflux disease, VUR, treated in children? About 1 to 3% of all infants and children have a condition called vesicoureteral reflux. VUR. Renal reflux is the most common cause of end-stage kidney disease in children. Some of the urine returns to the kidneys and can increase the risk of developing a urinary tract infection, UTI. UTIs that reach the kidneys can cause health problems. Therefore, it is important to diagnose renal reflux early and monitor it and treat it if necessary. Urology and robotic surgery, Professor Dr. Selçuk Selli talked about the treatment of reflux of the kidneys in children. Some babies are born with vesicoureteral reflux and the cause is unknown. Usually, a child's urethra is one way. Urine flows from the kidneys through tubes called ureters. The ureters enter the bladder through the bladder muscle tunnel, creating special one-way valves to prevent urine from returning to the kidneys. Urine in the bladder exits the body through another tube called the urethra. In children with VUR, the tunnel into the bladder for one or both ureters may be too short or tilted, causing urine to reflux. Vesicoureteral reflux can also occur as a result of the bladder not emptying normally. This is a less common cause of VUR. What are the signs and symptoms of kidney reflux? Kidney reflux is usually diagnosed in two ways. The former is identified by enlarged kidneys on ultrasound scans done in the womb. The other is detected in examinations performed when a febrile UTI develops. What tests are done to diagnose kidney reflux? Vesicoureteral reflux is diagnosed with a test called a voiding cystourethrogram, VCUG. No other test can replace this test. Children are placed on a thin probe during VCUG imaging. It is usually given with local anesthesia or sedation. It is important that the child does not move. VCUG is recommended for any boy or girl with a febrile urinary tract infection. What to expect during a kidney reflux test? A thin plastic tube called a catheter is inserted into the urethra, and the bladder is filled with a special fluid that can be seen on an X-ray. The test is painless. Children may experience some short-term stress and discomfort while the bladder catheter is inserted. X-rays are taken when the bladder is full. Vesicoureteral reflux is diagnosed when fluid travels in the wrong direction from the ureter to the kidneys. What other tests can be done for renal reflux? Ultrasound. This test uses sound waves to create a picture of the baby's kidneys and bladder. Recommended for all infants and young children after a first UTI. In this sense, it is the first test to be applied. Normal does not mean that there is no reflux in the kidneys. However, if it turns out to be defective, further investigations may be required accordingly. Scintigraphy. Scintigraphy, also known as a DMSA scan, is the gold standard method for detecting kidney damage. It may be ordered if the child has a urinary tract infection. It is not difficult to apply. The radiation dose is very low. It is applied in nuclear medicine clinics. Blood test. Creatinine measures kidney function. A child with damaged kidneys may have high levels of creatinine. Blood pressure. Blood pressure should be checked at least once a year. Children with kidney problems are more likely to develop high blood pressure. Kidney reflux is graded from 1, mild, to 5, worse. The degree depends on how well the urine is back and how wide the ureter is. Children with low grades of VUR, 1 to 2, present in early childhood have a chance of overcoming this without surgery within 1 to 5 years. How is kidney reflux treated? Kidney reflux treatment. It depends on the child's age, gender, degree of reflux. and whether it is causing any problems, such as multiple urinary tract infections. In addition, conditions such as kidney damage and bladder dysfunction pose a risk. In most cases, vesicoureteral reflux resolves on its own with age. However, defining this as the domain of a pediatric urologist and pediatric urologist. Treatment approaches include: Note: children with low-grade VUR can be safely followed up under the supervision of their doctor, pediatric nephrology, urology. This usually includes regular follow-up appointments. It may include imaging tests to make sure the kidneys are growing normally. Children with VUR should have their urine tested for infection when they have a fever and there is no other cause for the fever, such as a cold. Prevention, antibiotics. Some children are given a low dose of antibiotics every day to reduce the risk of developing a urinary tract infection while they wait to see if they have passed VUR. The American Academy of Pediatrics, AAP, recommends the use of prophylactic antibiotics mostly for children with higher degrees of VUR, grades 3 to 5. Endoscopic injection. A substance is injected into the area where the ureter meets the bladder to prevent urine from refluxing. It can be applied to children with frequent urinary tract infections and low-grade reflux, 1 to 3. Despite treatment with antibiotics, the success of the procedure ranges between 50 to 80%. Surgery. If VUR is severe and does not improve, or if there are frequent UTIs with fever, the child may benefit from surgery that corrects the leaky valve between the bladder and ureter. This surgery is called ureteral re-implantation surgery. Traditionally, it can be performed in the form of open surgery. The success of the surgery is more than 95%. A temporary stent may be needed to be placed in the urinary tract after open surgery. In this case, the stent should be removed from the urinary tract with a second procedure after 2 to 4 weeks. The hospital stay after open surgery ranges from 3 to 5 days. Robotic surgery. This is the most modern method in the treatment of VUR. In robotic surgery, as in open surgery, a success rate of over 95% is achieved. This is done by entering the abdomen from 3 different millimeter points. No muscle incision is made. Therefore, postoperative pain is much less. The recovery time is short. Patients can be discharged from the hospital within a day or 2. Since there is no scar, a cosmetically better appearance is obtained. This treatment is recommended in European guidelines for pediatric urology as an alternative to open surgery, which can be applied in experienced centers.